Good evening, everyone. Hi, I would like to welcome you to the Institute of Medicine Chicago Leadership Summit. And we're in for a great, great treat. As you can see, our speakers are packed in like sardines. First of all, I would like to thank you all for coming out. Hopefully the snow will hold off until we're done and back home and safe. So I would also like to say thank you to our sponsors. Tonight we have, let me introduce myself. I'm Courtney Avery Davis. I am the current president for the Institute of Medicine Chicago. And again, thank you all for coming out. I would like to say thank you to our sponsors tonight. We have Golden Square Association and Marketing Services, the University of Chicago Medicine, the Washington Square Health Foundation, ATW Health Solutions, Family Christian Health Center, the Portis Foundation, Midwest Business Group on Health, and Novo Nordisk as one of our sponsors for tonight. Tonight's presentations are going to be very, very exciting. Oh, I would also like to acknowledge all our board members are here today. If you could just wave, greatly appreciate it. Thank you all. Membership, so please join us if you can. So tonight our presentations are going to be delivered by an elite group that we picked and selected and was highly recommended by some of the membership that's on the Institute of Medicine Chicago Board of Directors and our fellows. So tonight we have Dr. Ige, who is the Commissioner for the Chicago Department of Public Health, and her career spans nearly 2 decades. Before her appointment as the Commissioner of the Chicago Department of Public Health, she served as the Managing Director of Programs at the Robert Johnson Foundation. We also have with us tonight Dr. LaMar Hasbrouck, who is the Chief Operating Officer for Cook County Department of Public Health. Dr. Hasbrouck is the Chief Operating Officer, and he previously served as the Executive Director of the National Association of County and City Health Officials, which represents the nation's 3,000 local health departments. Prior to that, he was the Director of the Illinois Department of Public Health. And I am going to pronounce his name, even though he taught me. It's fine. Okay, Dr. Jan Kitajewski. Oh, almost there. Director of Cancer Research at UIHealth. His areas of specialty are focused on vessel development, reproductive, I am not even going to try this one, enogenesis, and tumors associated with breast and ovarian cancer. He has extensive research and responsibilities in the area of breast and gynecology work. We also have with us Dr. Teresa Garate, who is the Managing Director for Health Management Associates, and she is experienced and an innovative leader with over 30 years of experience.
I started when I was 10.
But 30 years of experience leading systems change, innovation, and growth in complex environments of public health, healthcare, and public education, and higher education and government. She also served as Senior Vice President of Strategic Partnerships and Engagement for the Gateway Foundation, a national nonprofit serving people with substance use disorder in 9 states. And last but not least, we have Dr. Marilyn Griffin, who is with Aetna Better Health, a CVS health company, and she is a board certified in child, adolescent, and adult psychiatry, an accomplished healthcare senior leader with demonstrated experience in behavioral health care delivery and management, and she's currently the behavioral health medical director for Aetna, where she directs and oversees the behavioral health program for over 30,000 people. 370,000 people. Wow. Who was your therapist? So tonight we're going to look at the question of, now that we know who's in the White House, what would you like them to focus on and how would it impact healthcare and public health? And we'll first hear from Dr.
Thank you so much. IOMC, it's always a pleasure to be here.
and to have the opportunity to share my thoughts with you. So when this started, if you look at your agenda, it says thought leaders. So this is an opportunity for us to think together and share with you some of the thoughts going through our minds at this very interesting time in history. So I am Simbo Ige, Chicago Department of Public Health, and I have the very fun job of solving complex problems and safeguarding the health of almost 3 million people. So, but I love puzzles and I love problems. So I am going to invite you into my world a little and share with you why I am very eager to make some recommendations to the new administration. Because, next slide please. Now let me tell you what we are wrestling with. This is Chicago. Then if you have any doubt in your mind that this is a center of knowledge and medical advancement and innovation, raise up your hand so I can convince you. Okay, so no one. Next slide. So this is Chicago. Does anyone know how many health systems we have in the city? More than 30. That is more than 15 states in the city of Chicago alone. In this city, we have more than 350 federally qualified health centers. And so imagine my consternation when I see this kind of chart. And this is a chart that shows life expectancy. What is life expectancy? It is a cumulative metrics that looks at how long and how well we live, which is a totality of all of the health-related issues that we're facing. So in this city, there's some folks who live up to 88 years. And there's some folks who live up to 81 years. If a baby is born today and that baby has a good fortune of being Asian or Latino, this is how long we can expect them to live, given the current circumstances. And if you're white, a little below that. But if you're black in the city of Chicago, you can only expect to live as long as 69 years. So you see me scratching my head? That's how I scratch my head every day. Because they're like, okay, so we're at the center of knowledge. We have all this medical innovation and advancement. And for the last 14 years, we have not been able to figure this out. So in 2010, the Chicago Department of Public Health decided that we want to close the gap in life expectancy, right? Good idea. And we pulled together everyone in the city, hundreds of partners, hundreds of organizations, and say, yes, let us deal with this situation. That was 14 years ago. Now look at this purple line at the bottom. Did you see any rise at all in that line? No. So long before COVID started, see, at no point in this 14-year timeline have we seen any noticeable increase in the life expectancy of Black people. So long before COVID started. Next slide, please. So this is the problem. And now I also have the good fortune of being the first Black woman to serve in this role where I have the responsibility of making sure that the entire city is living long and living well. And then I have this problem facing us. So I said, okay, let me look at what is happening in the rest of the country. Maybe this is not a unique problem to Chicago. Now, yes, there is a gap in life expectancy in the rest of the country. But do you see what we see here? The life expectancy gap in Chicago is double the average for the United States. Now, that is not good. There are too many brilliant, smart people in this city for us to let this be happen. So, we have a unique problem here in Chicago that I want to make visible. That problem is worse than the average in the United States. I came from New York City. In New York City, the life expectancy for Black people in New York is 77. In Chicago, it's 69. And wait for it. Next slide, please. Now, before I even go here, now 69 sounds bad. But when we start to unpack that by neighborhoods, you know that there are neighborhoods in this city where the life expectancy is like even lower, 62. It's not that it was low, it's that it is getting lower. It is lower than it was in 2010. And so I start to ask why. So if there is a new administration that wants to do something, and we are the third biggest city in the United States, what will I tell that person? Like, I have a problem in Chicago that we've been trying to solve for 14 years, and it is worse than in many places in the country. And what is the reason? They're gonna ask me why. Why are we having this problem? So we start to dig into it, and I ask my folks, okay, make this pretty and nice so that lay people can understand it. And this is what we found. Chronic disease, homicide, opioid, COVID-19, accident, infant mortality, other causes. Is there anybody that is surprised by these primary drivers and the relative share that they have? Nobody. So we're very familiar with the burden of disease in the city. And is there anybody that feels like there is not expertise in the city to address this issue? Like we don't know how to manage heart disease, that's the problem. No. Or we don't know how to manage cancer. That's not the problem, right? So what is the problem? So these are the drivers that we have found. We know the solutions to this problem, so why are we here? Now, one of the problems I highlighted for you in a red box is that the budget for the City of Chicago Department of Public Health is around $1 billion. If you were to guess what percentage of that budget goes to chronic disease, anybody has a guess? Yes.
5%?
5%. That's a good start. Less than 1%. Why? Now, 90% of the money that we have, this is what it goes to. That thing in red. Now, look at the other side. How much of that is the driver of life expectancy? And why is this the situation? Because 95% of our budget comes from the federal government. We are the city, the only big city in the country that has that issue, where we are absolutely dependent on the federal government for what we do in public health. So we have great institutions of learning here. We have one of the best economies in the country. We are a hub for healthcare. But when it comes to public health, we are not doing so well in terms of where our priorities are. And we are very, very dependent on grants and time-limited silo funding that does not allow us to respond to what we know the problem is. So if I were to say to a president, I'll say, sir, you care about black people, right? That's a conversation that has been had. So this is the problem black people have in Chicago. And I would like to solve that problem. We have expertise, we're willing, but we need the resources. So that's one thing. Next slide. Now, the other problem is, so let's say we have money. And this is what typically happens. Again, I'm sharing my thoughts. These are the things I think about every day with you all. And I said, okay, so we have money for COVID and we have money for HIV. Our biggest budget is HIV. For 40 years, it's non-stop. We have a lot of money. I'm not complaining. I love the money that we have from HIV. But how can I replicate that for other things? And this is the reason why I am worried about it. Because we have made a lot of progress in many different areas. We are now looking at the possibility of getting to 0 HIV cases because we've had 40 years of consistent funding. But what good does that do though if you don't die from HIV, but you die from opioid overdose? What are we getting? Nothing. And if you don't die from COVID and you die from heart disease, same problem. So this is what we see. Now, the red mark there is heart disease. Sometimes we make progress, sometimes we don't. We have made some progress there. Good. Now, the homicide, these are the top 3. This is homicide in gray. Sometimes we make progress, sometimes we don't. Again, depends on administration, it depends on political will, depends on partnership, depends on societal attention. But what we do know is even when we make progress, every time there is a trough there is a peak of something else. Public health does not allow for vertical interventions. We have to look at the totality of the issues that are impacting us, because when we remove one, it is a whack-a-mole. We remove one, something else is in there. So I'll say, sir, you care about people of color, right? That's been the promise, yes. So we are dying at a higher rate than everybody else, and we need resources, but we also need resources for more than one thing at a time. Next slide. Now, I am a physician. There are many people who are physicians in the room. But even if you're not a physician, you know that if you have a headache, you can treat the headache. And you can have some relief from Advil or Tylenol or something. But it is in your best interest to find out the reason why you're having that headache. Many people for many years have studied why some people are healthier than others. We know it is a result of complex social factors. Now, this is just a refresher. If we spend all the billions of dollars in clinical care, we can only effect 20% change in the outcomes. Without addressing social economic factors, physical environment, health behaviors, the best we can hope for is 20% change. So, when we talk about social determinants, if we want to improve the length of life and quality of life, that's premature death, life expectancy, what all these measures that we use for advancement, it then is necessary for us to look at all of these different dimensions. We cannot accelerate progress or make sustainable progress without looking at the totality of the social conditions that continue to keep people in unhealthy states of health. So, how is this relevant? So every time we say give us money, someone says there's not enough money, right? Next slide. So we said, okay, we can help with that. And I said, folks, my team, we have amazing, we have PhDs, we have people with 3 degrees, etc. A lot of epidemiologists. Knowledge, expertise is not at home. So they can crunch data. And this is why I'm showing you this, because I can't just talk, but I want you to see the things that I see. And I said, please crunch the data for me. Put all the social determinants in a varied logistic, it wasn't logistic, regression model. And let's identify what are the ones that are the most important for us to address. We can address them all. And we are public health. I don't have money for housing. I don't have money for chronic disease either. So what's the point of me saying we need housing, we need safety? I can't do anything about it. So what are the things we can do something about? And if we wanted to prioritize, what would we prioritize? So we looked at protective factors and risk factors. And this is what we found. Now, if you put all of these things, dump them in a model, what emerges as the most important things? You see there, the blue are the protective, the red are the risk. Now, for every 10% increase, we use years of potential life lost here. Perceived neighborhood safety seems to have the most protective factor. If you live in a neighborhood where you feel safe, you are likely to live longer and better. And other things. I will leave you to wrestle with that when you have a minute. Next slide. Now, economic security and neighborhood resources. So you started with that model where we're taking those buckets one after another. Physical conditions. Perceived neighborhood safety is number one. Now, when we look at economic security and access to education, guess what? Median income is the most important thing. The median income for Black residents of Chicago is around $33,000. The median income for white residents is 90-something thousand. The median income for Asians is even higher than that. And the median income for Latino is 60,000. So there is at least a 30,000 gap between the average Black person and the rest of them. So if I give you $500 as guaranteed basic income, are you going to shift anything? Not likely. The gap is too wide. So median household income is the biggest headache that we have in terms of shifting health outcomes. And college graduation is important but not as strong. And then the risk factor, poverty, but there are grades of poverty, and that's what this is telling us. And then when we look at neighborhood resources and physical environment, when we put together everything in Child Opportunity Index, that is the most important thing, perceived neighborhood cleanliness, etc. So next slide. So where we landed, healthcare is important. But what is important in healthcare is not the things that you think. It is not routine checkup. It is not being uninsured. It is not receiving care in the last year. It's not unmet mental health care. What emerged as important in protecting from premature mortality is employment-based health insurance and having access to a primary provider. So these were really interesting findings. And if we start to explore solutions, so we know what the problem, we're looking for solutions. These are some recommendations we can make in terms of where should you invest. We may not want to say, invest more in healthcare, invest more, those are important things, but invest more in jobs and things that make people financially independent. And can more employers provide health insurance? We don't know who that's going to resonate with, and there are folks in the room, I'm not going to mention names, that may be helpful in advancing that message. Next slide. So, median income, perceived neighborhood safety, childhood opportunity index are the strongest protective factors. Poverty, food insecurity, hardship index are the strongest risk factors for years of potential life loss. Findings align with the literature that the timing, duration, and concentration of childhood poverty exacerbates the effect of health. It is not just about being poor. It is about how long you have been poor for, and how early in your life you started to face poverty, and how concentrated that poverty is. Residential concentrated poverty is one of the biggest limitations that we have. Now, this is not to excuse my responsibility as a commissioner of health. I am going to do everything in my power to advance vaccination and health and screening and promoting health behaviors. But when we look at why we haven't made progress in 14 years, we want the administration and those in leadership positions to understand that public health is more than the building and the staff, is more than healthcare. It also is investing in communities. So when we have this token grants and say you can only show a picture for vaccine, is it a good use of taxpayers' dollars really? Maybe not. If we want to make progress and we'll see impact for the long term, then we have to think a bit broader than that. Next slide. So the implications of this is we need collaboration. If anybody knows me, my constant refrain is we cannot do this work alone. We need everybody in the room. We need more people who are not in the room. We need people in education. We need people who work in economic policy. We need people who work in every sphere, every sector, to understand that whatever they do in those sectors impact health, and that we need more voices in the room, more people in the room that understand this relationship, because public health is never about one disease factor. It is multi-causation, it is multifactorial, it is multi-hands trying to solve the problem. So that's what I'm going to say as my recommendation. Next slide. Now, we came together as Big Cities Health Coalition to come up with some recommendations. So I'm not just, thinking thoughts in my mind. We are trying to put this out in the public, and this is on the internet. We have made policy recommendation on public health funding, urban health agenda, because there are some things that are just unique to big cities, and there are community safety based on some of the findings that we have had. Infectious diseases will continue to be important because we have heard that is the focus. As long as something can spread to someone else, everybody's up in arms about it. But the things that don't spread are also important, like community safety, substance use, and also tobacco, because we're seeing an uptick in there, even though we've made progress over time. Next slide, and I'm almost done. So why are these recommendations important? Because we know how things ebb and flow based on new administration. There are policies that we know work that can help address childhood poverty, because we know childhood poverty has lasting effect. And many people don't come out of it if we don't intervene early. But we have seen policies that help drop childhood poverty to historic low. But what did we do? We did not sustain. We let it lapse and say, look, child tax credit has an impact. It has an impact on health. It has an impact on childhood poverty. That will carry through the lifetime. Can we sustain some of these things? We also have evidence on what administrative changes can lead to in terms of health insurance coverage, especially in Medicaid. 1 out of 5 Chicagoans is on Medicaid. 1 out of 5 pregnant people is on Medicaid. So what you see there by year, how Medicaid coverage and total spending on Medicaid varies over time. What do you see in 2016? You see the yellow line drop there. You see the blue line drop. So it is important that we understand what the impact of those who are in administration can have on some of these policies. And these are the reasons why we are worried, and we want to make recommendations earlier sooner than later. Next slide. So now, what happens if these recommendations are not heard and are not honored? Our next step is, what can we do at the state level and what can we do at the local level? In the past, when federal Medicaid policies have shifted, the states have risen up to meet the shortfalls. So we are also working that angle and say, state, in case things drop off at the federal level, what can you do to buffer and solve for the problems Chicagoans are facing? So we're in that conversation. And Illinois is a fantastic state to live in. We have some commitment there in terms of Medicaid coverage, and I put that there because you can see how there's been a growth in Medicaid coverage in the city. And now we're in the middle of enrollment and we're working very hard with our state colleagues trying to push and get Medicaid coverage to those who can. Because Illinois has 1151 waiver that is coming down the pipe, it can cover housing, it can help with other things. So it is important that we all are part of this with your patients, in your emergency department, in schools, wherever we can let people know, get covered, get covered, get covered. If you don't have employee-based insurance, buy on the marketplace because you need all the protection you can get. If things fall off at the federal level, we need the state to come in and fill the gap, and we need everybody in the room to understand that this is a priority. So next slide, I am gonna stop there, but these are the things that I've been thinking about. I have big problems, we have ideas about solutions. We need an intensive kind of partnership to solve this problem. And I want you to go away knowing that we cannot solve for public health issues in silos. Not in silos of programs, certainly not in silos of discipline, and certainly not in silos of government. We need all hands on deck, and that's why I'm very excited that we have this partner, all these partners here who are wrestling with the same issues and brainstorming about solutions. So thank you very much, and I'm gonna get out.
All right. Well, I'm gonna learn a lot tonight. Good, that was good stuff. So I'm gonna go high touch, low tech, so no slides for me tonight. And I'm actually gonna try to read this off my phone, which I've never done before. The printer didn't work today, so I said, I'll take some pictures of the screen. So here we are. So I'm LaMar Hasbrouck. I lead the County Department of Public Health, where we're in the business of building healthy communities. And I'm delighted to join my esteemed colleagues here in sharing some of our thoughts tonight in terms of this critical question, new administration, so how does it impact folks? So we're all gonna come at it from slightly different angles, and I think it'll be clear what my angle is as we get going here. So I'm gonna start with 30,000. I'm just going to sit that on the brain for a second. 30,000. Some of you may know what I'm referring to, but 30,000 is the number of the additional behavioral health professionals needed in Cook County by the year 2028. Behavioral health workforce will need to increase by 50% to meet the current needs. And so the supply shortfall is significant because the pandemic, as we all know, unmasked a rising demand for behavioral health services, including depression, which went through the roof, anxiety, which went through the roof, and as it's been mentioned in the previous presentation, substance use has gone through the roof as well. So if we briefly kind of probe the challenge of substance use disorder for Cook County and discuss a little bit about the solutions, I would start by telling you that in Cook County during the pandemic there was a spike in substance use disorders. There was a spike in opioid use and opioid-related deaths. What do I mean by spike? 8,000 deaths between 2020 and 2023. That's 2,000 deaths per year, roughly. We know that fentanyl was involved in 90% of them, and we know that for every overdose death, there are approximately 10 times the amount of non-fatal overdoses that present to hospitalization. To hospitals, resulting in hospitalization. So in addition to the workforce shortage, there are stubborn disparities that we've learned by studying this problem. Namely, Black and Hispanic behavioral health workers are underrepresented in those higher paying jobs in mental and behavioral health, and they are overrepresented in those lower paying jobs, in those lower paying roles as well. And we know that there are serious maldistribution issues, meaning that the workforce gets real sparse as you move west and south from the city, the epicenter here, downtown Chicago. So Cook County is considering a number of solutions to address this, to address the workforce shortage, and I won't go into any specific detail, but I'll just give you kind of high level. What are some of the solutions we're considering to address this behavioral health workforce shortage? So one is looking at providing more competitive compensation. Another is increasing the exposure to behavioral health career opportunities from K to 12, so-called pathways and pipelines. Another is creating a $50 million regional behavioral health workforce fund. That's something where folks can earn and learn as they're being trained, training opportunities. They can kind of learn on the job, don't have to spend their own dime to get additional credentialing and education. Another is to improve the job quality and address this whole burnout issue that we're all experiencing to one degree or another. The other is to maximize the current workforce that we have by kind of streamlining, reducing some of the documentation needed to get your credentials and looking at additional service models that can help to maximize the current workforce. But in the meantime, we have to address the current needs. We have to address what's going on with this explosion of behavioral health needs. So to address some of these, using our local data to really identify some of the highest risk zip codes using something called the Social Vulnerability Index, we've identified some 30 or so high risk zip codes, which we try to target a lot of our resources towards for a lot of our programming. So we're doing that with this problem as well. We issued $5 million in grants in just suburban Cook County alone to community-based organizations to expand their harm reduction initiatives, services, including community-based drug checking. There's another $40 million that many of you may be aware of that's going out through Cook County Health at large for grants to kind of buttress some of the services throughout Cook County. There's law enforcement trainings to promote referral instead of incarceration. There's educational campaigns, one that we have called Get in the Lock Zone, which give folks resources and avenues for referral. There are naloxone vending machines. The city has them, we have them as well, including right there in the lobby of Stroger Hospital and a number of courthouses throughout both suburban Cook County and throughout Cook County, and there's more on the way. And then we've used a lot of our resources to kind of power what we're doing in the area of opioid education and naloxone distribution. So in suburban Cook County, for instance, there's been 22,000 some odd naloxone kits distributed. There's been 12,000 folks trained. There's been counseling to some 21 or so thousand folks in terms of the opioid education. So those are some of the things that we're doing locally in suburban Cook County, which is my 2.3 million, and throughout the county as a team. Now, what I've just shared with you is a scenario around mental health and behavioral health, but what I've really tried to do is give you an example that highlights the concept or the importance of localness. Localness. And that is, when it comes to governmental public health, there are some more than 3,000 local health departments across the country. If you've seen one local health department, you've seen one local health department. And there are, like I said, more than 3,000 and nearly 100 right here in the state of Illinois. They range in size in terms of their employees, in terms of their budget, in terms of their expertise, also in terms of the assigned jurisdiction. They are and should always be considered agnostic by design, and they all strive to provide what we call the foundational public health services to the folks that they serve. These include foundational areas such as communicable disease, environmental health, chronic disease prevention, MCH, etc. Also foundational capabilities, that is the things that local health departments should be capable of doing, things around communications and disease surveillance, emergency preparedness and response, community partnerships, and the like. But each local health department is unique in their customized charter, so to speak, to address the health priorities of their populations the best way they can, from where they are, given the resources at hand. The success of local health departments, any local health department, is going, or their failure, is going to result and going to depend on, in my opinion, 5 factors. And I'm going to give them to you in highest priority. The first one is political will. And I mean local political will. The second is leadership and vision. The third is strategy. And then when you have that all together, then you get the funding to power that strategy and that vision. So the resources in terms of funding and talent is number 4, followed by an activated community partnerships. And because the constellation of these five factors, they vary from every local health department, their operations and ultimately their impact on the jurisdictions that they are responsible for will also vary. So that brings us from the concept of localness to this question, which is, the election's over. What does it mean for healthcare and public health? So I want to recognize, first of all, I want to recognize that half of the country may be recovering from their mourning period. Half the country feeling, having feelings of loss, and it may negatively impact some of our staff and the morale things. So we just got to recognize that, make sure we're supporting our staff through it. But I also understand that the other half of the country is feeling very celebratory. Feel like it's raining money out there. They're more hopeful in terms of this new administration that's coming in. So let's just recognize that and address that. And then I'm going to answer this question by saying that during my 30-year tenure as a public health professional, I've witnessed 9 elections, participated in them, and I've survived the administrations of 5 different presidents. And it is from this vantage point, as someone who has worked at every single level of the governmental public health, that's local, state, federal, including CDC, and international, World Health Organization, I'm going to share with you my perspective. I don't have an ask of the government. I have an ask of the new administration, President-elect. What I do have is an informed perspective, and I'll share it with you tonight. Hopefully we can use that to facilitate some of our Q&A. So here's my prediction. It's going to be some staff turnover. There's going to be some realigned programs and policy priorities and some sunsetting and going away. There'll be introduction of radical ideas. There'll be introduction of reasonable ideas. There will be new mandates, some funded, some unfunded. There will be disruption and in some cases discontinuation of certain funding streams. There will be a shift in the research agenda, namely impacting NIH, National Institutes of Health, and the CDC, where I spent 11 years of my career. There will most assuredly be events of significant public health interest that will stress test the administration as it has with every other administration. If it's AIDS, the Clinton administration, or SARS and Katrina, 9/11, if it is the swine flu, H1N1, healthcare reform, Zika virus, COVID, if it is Mpox, and who knows what's waiting for this next administration as they take the reins. So there will be that. I can predict that with almost 100% certainty. And I can predict that we will get through them. It's not always going to be elegant. There'll be some extra lives lost here and there. There's going to be some sacred cows sacrificed along the way. There's going to be some battles around science, etc. But we will get through them. And I do believe that every challenge is an opportunity in disguise. In fact, the study that I talked about, the 30,000, beginning of my comments, was funded through some of the money that came for COVID relief. And there's been a lot of initiatives in health equity and other issues, behavioral health and expanding behavioral health, and a lot of services, as has been mentioned. They're going to be time limited, money will go away, but they have been powered and funded from the monies that happened as a result of the pandemic. I also believe that every challenge that we face is an opportunity to become more than we've been before. So through this lens, I believe that the challenge of disrupted federal funding can lead to the opportunity of state and local prioritization of their investments, the local investments, and the expanded partnerships with businesses and philanthropic organizations. I believe that the challenge of disinformation campaigns, which will certainly come, in my estimation, presents the opportunity for clarity of our public health messaging about prevention and health promotion. I believe the challenge of undervaluing science will present an opportunity to show the transformative impact of science-based solutions, because after all, it was the vaccine that's credited for saving millions of lives, not Clorox bleach, not ivermectin, but the vaccine. So at the end of the day, the science will bubble to the top. I believe that the challenge of dismantling prevention programs and services will allow us to demonstrate how public health is a best buy, with an ROI ranging from 125% to 3,900% in terms of our initiatives. So in closing, we cannot, in my opinion, hitch our wagons to any politician, to any personality, to any administration. Ours remains a government of the people, by the people, and for the people. And regardless of who's sitting in that seat and the administration they drag in, it is not going to change the local priorities of political will, of leadership and vision, of strategy, of funding, and of our community activation. At the local level, we understand we have a blend of funding that comes from federal, state, and local, and other places. We need to start looking at other places, and we need to understand that that local impact is always going to be the driving force. So experience tells me, at the end of the day, that there will always be a concerned public, there will always be some adults in the room during any administration, and ultimately the driving ideology, in my opinion, should be public health for the public good. Thank you.
First off, I couldn't agree more with the sentiments and the descriptions given by the first two speakers, and I'd like to build upon some of those concepts for sure. With regards to building the behavioral health workforce, I'm happy to say my daughter is close to graduating as a clinical psychologist. It's interesting working with high-risk youth in the juvenile detention system. So one out of those 30,000 may be on their way. Well, anyway, let me, I'd like to backtrack a little bit and introduce myself. My title, my actual title is the Director of the University of Illinois Cancer Center. We are a cancer center that is approaching a moment to try to achieve what's called National Cancer Institute designation. And those cancer centers typically blend very intricately the healthcare system with the research operations. There's a virtual partnership between research and healthcare, and those are the criteria that elevate you to this highest level of national designation. There's 72 cancer centers that have NCI designation. The University of Chicago was the first in Illinois with the launch of the War of Cancer, a war on cancer actually by Richard Nixon. The NCI was formed when the University of Chicago became NCI designated in the 1970s, Northwestern in the 1990s. But while states like California, Texas, Florida, New York continue to have newly designated cancer centers, sometimes up to 10 or 11, Chicago has only had 2. And so our job here, as far as the job that I was brought on board to do and following the footsteps of Dr. Robert Wynn, who was the former director of the University of Illinois Cancer Center, is to bring a designation, a third designation to Illinois. Now, why is this important? It's important for Illinois, but I think it's very important as a model for addressing healthcare in many other ways that have been addressing the problems in many ways that have been pointed out about access to care, and more particularly access to the highest level of cutting edge care. Few of these NCI designated cancer centers that have blended this research and hospital health infrastructure really truly have overcome the problem of allowing access at these NCI designated cancer centers to underserved, underinsured, uninsured, and a variety of folks living in a whole variety of different conditions, with some notable exceptions. And so the UI Cancer Center was built largely as a state hospital system-based cancer center that would work as hard as we possibly can to overcome that particular problem. Bring in diverse patients, irregardless of their means, where they live, their background, their insurance mix, and assure that they're getting cutting-edge cancer care. And I'm happy to say that we built out this model. We refer to it as the community to bench model. Bench meaning the research bench where discoveries are made. The traditional model could be thought of as research discoveries are made, a new drug or procedure or health procedure is brought forth, and then the thought about how do we assure that everybody gets access to this treatment is brought to the fore. So a cutting-edge drug is made, and then it's being put into use. But there's many, many examples where that is not optimal. For instance, key diagnostic tests for prostate cancer and breast cancer have caused misdiagnosis of black women of what the treatment options should be compared to white women, based on the test being developed strictly by incorporating white women in for this diagnostic test. Similar cases exist for prostate cancer. So community to bench asks, is a model whereby community input is infused at every stage of the process of discovery, from the most fundamental research to translational research that's developing new drugs to population health-based research. And how is that done? Well, first off, it's done by assuring access. As a University of Illinois health system, we take in patients that are on Medicaid, and about 1/3 of our patients that come in for cancer care are on Medicaid. And we take in uninsured patients, and in many cases try to find insurance opportunities for them. And we assure that they have access, regardless of their insurance mix, to cutting-edge clinical trials. Clinical trials can be viewed in a variety of different ways. One can think, well, clinical trials are a risky experience for an individual. An individual is being subjected to something that is unknown, and the treatment is not known. And there could be, and have been, a number of cases where clinical trials have not been safe and effective and fair. However, in the cancer space, what's happened is the development of new opportunities to treat has been moving so fast that we have gone over the last 20 years from choosing chemotherapy, surgery, or radiation therapy to now adding on precision drugs that depend on defining genetic mutations and having a drug that just attacks that particular change. Why is that important? Because that drug would work if you have that genetic change, and should only be used there, and it shouldn't be used if you don't. So it's a very selective, precise decision-making process of hundreds of new drugs that require genetic analysis followed by treatment. More recently, immune oncology has been brought on board, which harnesses your own immune system to attack cancers. And finally, cell-based therapy, which takes out your immune cells, trains them to find and attack a tumor, and redelivers those immune cells back into your own body. And many of those, for instance, like the cell-based therapy, in that particular case, that particular type of treatment might only require first surgical removal but no chemotherapy, no other immune oncology treatments, but simple reintroduction of your own cell-based therapy to treat those tumors. Now, what has happened is those developments have really had significant impact on mortality rates across the U.S. And the ACS and the National Cancer Institute reports that over the last 18 years, there's been a 25% reduction in mortality for all cancer types, a success story. They anticipate that in the next 15 years, that number will be a 50% reduction. So a big success story in treatment and allowing for more higher rate of survival after treatment, detection, prevention, and treatment of cancer. However, if you look deeper at the statistics across ancestry, ethnicity, and economic means, there's a disproportionate success in improving mortality rates of some populations and not others. So this is a significant issue that has to be addressed. In addition, there's a troubling trend on the horizon because incidence rates are going up. So even though mortality rates are reduced quite significantly, for reasons that we don't clearly know, incidence rates are going up. And there's a very strong trend that age of diagnosis is going down quite significantly. So the percentage of patients who are being diagnosed in their 30s and 20s for adult cancers is increasing. Now, the burden on the health system of this shift is, it can be enormous. In some cases, the shift might be secondary to higher rates of obesity, which are driving endometrial, breast, liver cancer rates to increase. But in other cases, truthfully, the researchers and the research infrastructure doesn't really understand what's driving these changes. In addition, many more people are surviving with cancer. The pool of individuals who are surviving with cancer because of the reduced mortality rates has increased quite significantly. And there is a very deep and important need to treat the cancer survivors for a variety of reasons. One, cancer treatment-induced mortality, such as effect of the brain, heart, and other organs after chemo treatment, even dental care, skin care is all affected by chemotherapy. And lymphedema can be induced by surgical procedures. And so there's an important shift that we as a cancer center and many cancer centers and many hospital systems are making to assure that survivor care is of high quality as people are surviving longer. In addition, anxiety and fear around cancer is an important consideration and needs to be treated. So how do you assure that this precision oncology is equitably distributed? So that's what we refer to as equitable precision oncology. Well, there's a variety of things that, and I'll just mention a few, that we have done as a cancer center and used as our model and is the basis for why we are seeking NCI designation. One is assuring that the most cutting-edge diagnostics are available to all. A major trend in cancer detection, as you know, there's a limited set of means for detecting cancer at early stage. Skin cancer, colon cancer, breast cancer, prostate cancer, to some extent liver cancer. But many other cancers like ovarian cancer and pancreatic cancer do not have early stage detection methodologies for radiological means, for instance. But there's a growing number of liquid biopsy or blood-based tests that can capture DNA shed from cancers that have hallmarks of that cancer. And this includes dozens of new tests that are working their way through the system and seeking approval for use and coverage by insurance. One example that I think is the most illustrative is a test by a company called Grail, called the Garate test, which is described as a test that can pick up signatures of 20 individual different cancers, including pancreatic and ovarian cancer. This test has a lot of power, but a lot of risks because it's not clear if the signal is detected, what is the course of action, because in many cases the cancer can't be detected by radiological means at the stage of detection. So what exactly is the course of action in the healthcare system? On the other hand, the opportunity to capture a cancer in stage 1 or stage 2 through a simple blood test that can be done anywhere in Cook County could be transformative. So we've worked hard with Grail to bring their clinical trial, to open up a clinical trial site at an FQHC at the Mile Square Health Center at UIHealth, in collaboration with Dr. Jasinoff and Jasinoff and your colleagues in your organization. And the goal is to assure that irregardless of your insurance mix, you have access to a primary care site that would be offering a test, and that the test performance is being evaluated by patients who are coming in those kind of circumstances. None of the other clinical sites that have opened up for this test in this Pathfinder 2 trial include FQHCs. We are the first to do that, and in fact, the only one to do that. Once again, the power of doing that by utilizing community-based hospitals, FQHC, primary care sites to test, bring on board, and approve the most cutting-edge diagnostic tools and precision oncology tools is transformative. The other thing we do is reach out to hundreds of different community partners. As a cancer center that's seeking NCI designation, I oversee an educational component, a research component, community outreach component, a training component. We run the clinical trials office, and I have a responsibility in cancer care by co-overseeing the oncology service line. And that assures very tight integration between those, that research and healthcare part of the operation. So by creating a model where clinical trial accrual, access to cutting-edge precision oncology care is all facilitated through networking with safety net hospitals, FQHCs, as well as other partner hospitals, for instance, Cook County and Rush and Northwestern University of Chicago. The goal is to assure that every element of research, every success of research, every accrual on the clinical trial, every onboarding of new technology is accessible across the spectrum of our patients within Cook County. Now, we're hopeful that this model will be successful for Cook County, and we're looking forward to future partnerships. But we also, I'm delighted to say, after a 30-year history of having a cancer center at the University of Illinois system, for the first time in our history, I led the submission of the grant for NCI designation. We've completed that process. This is a 1,500-page application that undergoes a pretty intense review. So we've completed what's called a site visit review and are awaiting a decision from the National Cancer Institute about how things about bringing on board a third cancer center to the UI system. And I would just say for the future administration, the benefits of using a model like this, or using a model where access is given to all individuals regardless of economic background and insurance, is not only that we are strong as a country. After all, E pluribus unum is meant to say that all of us work together, we look out for one another. But it's also strong for our economy. It's the best way to assure the strongest, most active workforce, a long life, long vital life. And I would say that the investment that will be made to assure that the NIH, the NCI, Medicaid coverage, food assistance, and as well as economic stimulus would have immeasurable impact across the United States. So thank you very much. I look forward to that.
Good evening. Buenas noches. Are we still awake? How much wine have you had? I haven't had a glass yet, so I still have a lot of energy. My name is Dr. Teresa Garate, and I am Managing Director for our Behavioral Health Practice at Health Management Associates, HMA. Hopefully you have heard of us, and if you haven't, I'll make sure you do by the end of the evening. It's great to be at IOMC. When I had the privilege of helping to run the Department of Public Health with Dr. Hasbrouck many years ago, I used to be very involved at IOMC, and then they forgot me, and I haven't been invited for a long time, so it's really great to be here. So Dr. Ige and Dr. Hasbrouck did such a great job, not that Dr. John did, but really setting the stage for what IOMC is all about, right? And I was telling my colleague over there, you know, it's the intersection of healthcare and public health and advocacy and education. And it's really critical to have that conversation from that perspective. I'm an educator. I'm not a physician. I'm not a public health professional. I had the fortune of being appointed as the Assistant Director for IDPH under Governor Quinn, and it was the best thing that happened to me because I went from being a special educator, working with children with emotional disturbances and behavioral health needs that we're all talking about, to then thinking about it from a public health perspective. And education and public health are like Reese's peanut butter cups, right? Chocolate and peanut butter, they go together so well. I used to tell people, you want to know something about a community? Walk into the school and walk into a hospital. If the clocks aren't working, if the grass hasn't been cut, if no one's in the parking lot, this is a community in need, right? So the marriage of the two are really important. So from my perspective, and I had a whole thing here. All good teachers have lesson plans, and then they get thrown in the garbage when things change. So I want to talk a little bit about why we are here. We're here because of the people that we're advocating for, because of the people that we're trying to impact, right? So one person at a time, one community at a time. So something that my colleagues haven't said or haven't really talked about is stigma, right? There is a lot of stigma in every topic that we're talking about. My world as Managing Director for Behavioral Health for a very large consultancy and research firm is, I see it every day, right? I see that we're trying to fix this problem and fix that problem. But the elephant in the room is that the reason that the pictures that Dr. Ige put out there is because of stigma and racism and discrimination. And when you talk about substance use disorder or mental illness, you know, I had breast cancer. I'm a breast cancer survivor, 10 years this past year. So, you know, cancer is important. When I had my breast cancer, I had the best care. I went to Rush, I had great oncologists, all this stuff happened. And at one point I said to my physician, hey, I lost my boob. I'm really sad about that. Can I see and they're like, what? I'm like, this is impacting me, and it's impacting my head. But nobody thought about that. Nobody thought about, oh wait, there's this whole other piece of it, right? So we talk about cancer. There's not as much stigma, right? It's not your fault that you got cancer, but it's your fault that you're feeling bad, and it's your fault that you're using the substances, and you know, there's all this other stuff that's in there that we don't address. And so when we think about this new administration or whatever administration, whoever is sitting there, it's really about thinking, how are the things that are invisible, the attitudes impacting what we're doing to respond to this public health epidemic? I'd like to remind everybody that before COVID, substance use, mental illness, and overdose was the #1 public health epidemic of our time. And so we kind of forgot that when we went into COVID, not to minimize that. But guess what? That is still, and it's growing, right? So when you think about the solutions, I almost think about, there's no little wall outside of Chicago, there's no little wall outside suburban Cook County, and I work with these partners all the time. There's no wall around the person, right? When we think about solutions, we have to think about person-centered care. Meet people where they are. Sometimes, I was a teacher, so I talk about stories. I remember meeting with a family of a child with a disability, a young adult child. And, you know, the young adult child said, Terry, that's great. You built something that you think is best practice. That's not what I want. That's not what I need, right? So thinking about person-centered and what they need and how do we build around them. So my talk, my notes had updates about SAMHSA and CMS and NIDA and CDC. Right there, it's confusing. How many federal agencies are impacting this, right? How many federal agencies are giving out money? And they give you out money for this thing, but you can't use it for anything else. But wait, this person who's coming to me today for, you know, food stamps can also use these other things, right? So the beauty of public health is that if we are successful public health professionals, we're in the background. Nobody knows that we're there, right? We're just doing all the prevention and all the things that if we're working, then there's no crisis. That is what I learned when I went to public health. Can you tell I really liked it? It was like the best and the hardest job I've ever had. Because I had to work, no, I'm just kidding. We only worked together for a little time, but still did a lot of great things. So I'm not going to take a lot of time because my colleague has to go and we're already over time. But I think if there's anything to think about as we think about the future, and yes, I am very, very glad that I live in Illinois. I grew up in Florida. I'm so glad I do not live in Florida. I've been here for 36 years. This is home now. But one of the things that I want us to think about is as we watch what happens in DC and here, really thinking about making people coordinate and talk to each other. Like, I mean, literally, I can send this to you. There's a lot of great things that are happening. There's grants for suicide prevention. There's a push to get people with lived experience to join committees for NIDA. There's new CMS rules that were passed in September for MAHIPA, the Mental Health Equity Addiction Act, right, which is all about holding payers accountable. Dr. Ika talked about commercial insurance and Medicaid. Guess what? Commercial insurance, payers are a big, they have to carry part of the burden here. If people don't have access, then they're not going to get treatment. And sometimes even people with insurance don't have access, especially when it comes to behavioral health and SUD. People don't understand that SUD is a disease of the brain. They can't get their heads wrapped around that. I have sat in front of testimony, in front of legislators, given testimony, and argued about how it is a chronic disease and it's a disease of the brain. And it's very difficult for people to wrap their brains around that. And when Dr. Young was talking about, research, well, this is the most important organ of the body, the brain. I happen to be the chair of the NAMI Chicago board as well. My fellow board members here, Dr. Swami, and we talk about that all the time. Okay, so you are going to do a test on my kidney, but to try to figure out why I'm not responding to a certain type of intervention for substance use or mental health, no one's doing a brain scan. Why not? Right? There needs to be a focus on understanding how the brain is impacting the rest of us. It's great to be the managing director for behavioral health in my company because I get to touch lots of different things, right? Behavioral health, mental health is everywhere. Everything we've talked about, trauma-informed, the children, everything is going to be impacted by that. And so as we think about the new administration and as we are coming together, call to action is thinking about holding people accountable and thinking about our local community, what we can leverage here in the state of Illinois with 1115 waivers, really focusing on the social determinants of health and health-related social needs to try to make an impact. We know what works, now we just, I think, have to do it. So with that, I'm going to stop. Thank you.
All right, good evening, everyone. We're in a home stretch. So I'm going to ask everybody to just stand up for a second. We've been sitting for about an hour, right? Stretch here. And I promise I won't be before you talk.
Take your time.
All right, so when you're ready, you can have it. The panelists and my colleagues before me really prime the audience and the stage for the things that I'd like to share with you today. So again, good evening, I'm Dr. Marilyn Griffin, and I'm delighted to stand before you today as a physician educator and a healthcare leader. I'm also a Black woman. I'm a daughter, I'm a sister, a wife, a bonus mother, who was born and raised on the south side of Chicago in the Auburn Gresham neighborhood where my mom still lives. And as a true Chicagoan, I must rep my high school. Whitney Young Magnet High School.
Go Dolphins.
Any Dolphins in the building? All right. The Dolphins everywhere. That's why I rep my high school. So I'd like to thank the Institute of Medicine for hosting this important summit. and providing a platform to discuss the future of healthcare in Illinois. My background and expertise and experience places me in a unique position to enhance healthcare delivery and drive improved healthcare outcomes through innovative, evidence-based approaches and by building strong partnerships. I think the theme throughout tonight is collaboration, partnerships, local initiatives, and increasing access to care. The recent election has been a pivotal moment that presents new opportunities for these collaborations among healthcare providers, policymakers, and community stakeholders, because we cannot forget the communities that we're serving. While the political landscape is ever-changing, at Aetna Better Health of Illinois, our focus remains steadfast. We want to simplify the Medicaid members' experience and improve access to care, and we want to meet the members' health-related social needs. We've had some person talk about the 1115 waiver. And Aetna's priorities are aligned with the governor's and the Department of Health and Family Services' overarching goal to provide accessible, equitable, and sustainable healthcare solutions for all Illinois residents. Now, how do we put our priorities into action? At Aetna Better Health of Illinois, we are member-centric, and we work diligently to simplify the member experience. This starts with clear communication. So providing clear and understandable information about their benefits, about the coverage, member rights, help our members to make informed decisions about their care. With technology and digital tools, we streamline communication between members and their care teams. We have implemented user-friendly mobile apps and online portals that allow our members to access their health providers and teams and their own health information quickly. They're able to communicate with their healthcare providers, and they're also able to schedule appointments. All of this at their fingertips and at their convenience. We even have a chat bot to ensure that our members can get the help that they need whenever and whenever they actually need it. However, we all know that clear communication and innovative technology is not enough to navigate this complex system that we call healthcare. My sister, my husband, and I are all in healthcare, and sometimes it takes all three of us to put our brains together and our heads together to try to get my mother the care that she needs. So in collaboration with each of our members, we develop individualized care plans so we can understand what's important to them, because they're the ones that matter. And we consider their specific needs and their preferences. Our care coordinators and case managers take the time to get to know them, and they build trusted relationships that can positively impact their health outcomes. We offer integrated services, coordinating the members' physical, and we've heard a lot about behavioral health, but their physical and behavioral health needs. Now, I know I just said that technology isn't enough to successfully navigate the system, but guess what? It does help. Prior to the COVID-19 pandemic, telehealth really wasn't embraced. But at Aetna, since the pandemic, we've seen a nearly 15% increase in the use of telehealth. And telehealth has actually expanded our access to care. And it allows us to bring care to the member. This is particularly important for Illinoisans that are in underserved areas or in rural areas where they don't have access to providers. We have an array of telehealth providers that specialize in chronic disease management. We heard a little bit about that. Maternal health, I'll tell you a little bit more about that. Mental health and substance use disorders. This ensures that every member, no matter where they live, can receive comprehensive care that they deserve. At Aetna, our whole person care approach also includes equitable solutions to address members' health-related social needs. People often ignore their health when they don't know how they're going to meet their basic needs. Addressing these primary needs are essential for individuals to be able to prioritize their health and maintain their overall well-being. And as we prepare to support the 1115 waiver, we've made investments and implemented partnerships with community organizations to deliver targeted support for housing, for food insecurity, transportation, and employment. With the help of our $100,000 community investment, one of our community partners was able to house 13 unhoused families in Chicago within the Cook County area. And we're very excited and proud about that initiative. Now, our health plan is deeply focused on maternal health. Core maternal health outcomes are a critical issue negatively impacting Black women like myself. Just last year, the Illinois Department of Public Health released the Illinois Maternal Morbidity and Mortality Report. I don't know if any of you read it, but did you know that Black women in the state of Illinois are twice as likely to die from any pregnant-related condition? And did you know that Black women are 3 times as likely to die from pregnancy-related medical conditions as white women? 3 times. Or that the leading cause of pregnancy-related death is substance use disorder. At Aetna, we are working diligently to bend this curve. We have enhanced our maternal health program by providing doula services and other great tools to connect women and their families to culturally sensitive, clinically sound support such as lactation consultants, mental health care, parent coaching, member education, and high-touch care management. These services have all been proven to improve birth outcomes and overall maternal health. By prioritizing maternal health, we lay a strong foundation for the future well-being of families and communities. Now, as a child, adolescent, and adult psychiatrist, I'd be remiss if I didn't take the opportunity to discuss behavioral health. Behavioral health is a public health priority, not only in Illinois, but throughout the country. We have seen rising rates of mental health conditions and substance use disorders since COVID, as my colleagues have already mentioned to you. And if you didn't know, there was already a child mental health crisis before COVID. This has led to longer wait times to care, higher illness acuity and burdens within the healthcare system, and increased utilization of emergency rooms and inpatient levels of care. By strengthening our partnerships with providers, community-based organizations, and increasing telehealth providers, we are expanding access to quality behavioral care for our members and their families. Through expanded telehealth partners, we have achieved a 19% reduction in the intake referral to treatment time and a more seamless member experience. We actually have a telehealth partner who there's a 7-day window from referral to treatment. Now, 7 days is much better than 3 months, which is what it was for me when I was providing direct care, or even now as much as 6 months. And this partner they're such a good partner that they'll let us know when they have same-day availability if we have members with some acute needs that need to be seen right away. So the use of telehealth and digital tools have extended the reach of behavioral health professionals because we know there aren't enough of us to meet the need. But yet, according to the National Alliance for Mental Illness, about 61.8% of 12 to 17-year-olds in our good old state of Illinois have depression. And they did not receive care. This gap in care is alarming, and it's influenced by a mix of factors ranging from the workforce shortage, access issues, insurance challenges, to stigma, cultural and parental factors. Understanding the need for a systemic change, our governor announced the Children's Behavioral Health Transformation Initiative to improve the delivery of behavioral health services to children and adolescents throughout the state of Illinois. Aetna Health of Illinois' Children's Behavioral Health Program is in alignment with this groundbreaking initiative to ensure that children and families receive timely and effective behavioral health care. Our collaboration with mobile crisis response providers and care coordination and support organizations have led to a decrease in behavioral health inpatient admissions following a crisis event. And we provide wraparound services support for children, adolescents, and their families, giving them the tools that they need to remain in the community post-crisis. Before I take my seat, I'd like to just reaffirm that Aetna Health of Illinois is dedicated to serving the most vulnerable populations across the state of Illinois. We're focused on Medicaid members who rely on coordinated, comprehensive, hyper-local care to manage their individual health needs and help to improve their daily lives. Our priorities are in alignment with the state priorities, and again, we are focused on simplifying the member experience and increasing their access to care, helping them to navigate this healthcare system, and meeting our members' health-related social needs. We know that that's a cornerstone of whole person care. Improving health care for Illinois residents requires collaboration, multifaceted, hyper-local approach involving all of our policymakers, our providers, the insurers, and again, the communities and the individuals in which we serve. Aetna Health of Illinois' efforts to simplify healthcare and to address social-related needs are not isolated initiatives, but part of a larger vision to create a healthier, and more equitable Illinois. Thank you.
I would like to say thanks to all of our panelists. I went up and down, and back up and back down, but there's still hope. So thank you all. Right now we'll take questions and answers real quick for the next couple of minutes from our audience. You want to stand or do you want the mic?
Thank you, Bill. Okay, that works great. Thank you, panel, for your presentations. Marilyn, you talked about the telehealth. And I'm interested in what the panel thinks about integration of primary care and mental health providers, and the use of community health workers who've been trained in mental health first aid and other tools. think those are opportunities to expand access.
I can start. I can just say absolutely. There are studies that show that community health workers, as well as peer advocates, can really help to help individuals build trust in the system, especially those from marginalized communities. So, yes, there is room and there's place, and we have community health workers and peer advocates within our system.
Yeah, I guess I would add for people living in long-term recovery, becoming a certified peer recovery specialist is really important. I think a lot of those people want to give back. Unfortunately, the rates of payment for those professions is very, very low. And as we all talked about workforce, if we had great reimbursement, we wouldn't be having a problem, right? But that's a big issue. And so those positions that are so powerful for people living in long-term recovery, sometimes they come back, but they're making $20 an hour, maybe that, if that. And so I think that's a big challenge. But yes, definitely. Research also shows that once peers are involved, people live in long-term recovery for a long time.
This question is for Dr. Chen. Is the University of Illinois applying as a comprehensive cancer center or a clinical cancer center? And then was there any thought about possibly being part of a consortium?
Yes, so can you hear me if I don't use the mic? Yeah, here we go. Well, we're applying for what's called a clinical cancer center. Number one, you need to start with the clinical designation before you can transition to the comprehensive. So we're starting the journey. Our catchment area, which is the area of maximal impact that we described, is Cook County, but we have the potential to grow into northern Illinois. In fact, no NCI designated cancer center covers central Illinois right now. There's Washington University in St. Jude's to the south of us. There's the University of Chicago, Northwestern, and even Madison to the north of us. But one of our aspirations is to grow into rural spaces. And finally, if we're designated, we're really excited about creating partnerships. The University of Illinois is already starting to begin a stronger partnership with Cook County Health System, with Cook County Stroger, along with Russia in partnership. And because the patient mix that's coming in to Cook County Stroger resembles closely the patients coming into UIHealth, that is a really strong natural partnership for us. So yes, we are very eager to grow across Illinois and to partner with other health systems as we grow a consortium.
Okay. Thank you.
Thank you for your question.
Hi, Wesley Evelyn from Health and Medicine Policy Research Group. My question for Drs. Ige and Hasbrouck. You both touched briefly on funding for your departments. I have a question about what roles or what positions would you want funding for? If we had, let's say if you had somebody, a political leader said, we're going to give you this much more money, what would you fund? What would be your top priority?
Yeah, okay, let me start. So for us, it will be the chronic disease, the top three: chronic disease, homicide prevention, or violence prevention, and then easier. So for us, we've been focusing on closing the life expectancy gap. So those top three for us are chronic disease, especially heart disease, violence prevention, and then opioid overdose prevention. And a lot of our funding, like 80% of the funding that we have, goes to delegate agencies or community partners, and including community health workers. And that's one of the areas where we really desperately need resources so that we can partner with those on the ground who have the trust to help connect people to resources.
So I can answer with precision because we actually commissioned a study on this. And so we know not only how many we need, but we know where we need them. As I recall, the top three areas, the study revealed that we're about 100, 120 position short for our jurisdiction in order to meet the foundational public health services that I mentioned briefly. And some of those areas that we need help in is the community health workers. That's, I think, our number one. I think number two, what may have been our communicable disease team for the outbreaks and investigations and contact tracing and all that kind of stuff as well. And then I think environmental health may have been our third. They do all the inspections and all the other stuff that I'm sure you know. So those are some of the top three, but we have a very elegant study that basically lays out where the deficits are, how much it will cost just for the salaries for those folks, not to mention other things. So we kind of have a good roadmap as to where we need to go, and now my job is to continue to do the advocacy for the political will piece so we can cross the finish line. Thank you.
Hi, excuse me, good evening. I'd like to introduce myself. My name is Archana Chatterjee. I have the honor and privilege of serving as the Dean of Chicago Medical School at Rosalind Franklin University in North Chicago. I'm here tonight with two of my colleagues. We spent 2 hours sitting in Chicago area traffic to get here, so apologize for the delay, but I wanted to thank you all for your presentations first. This was an amazing meeting, and I've come to this event every year, and I think it gets better every year than this, so this is fantastic. There's a couple of things I wanted to mention. We are blessed with a large number of medical schools in this area. And I would say, speaking on behalf of my fellow medical school deans, please do count us as your partners in building that workforce that you are talking about. One of our students was here, he has stepped out, but the support that we provide to these students, the education so that they can learn what the needs are and they have the desire to serve this community, we need to foster that so that they can build on and expand the work that you all are doing. So that's the first point I wanted to make. The second is much of the focus of your presentations tonight was on this area in the city or county, which is understandable. However, don't forget those of us who are a little bit to the north in Lake County, because that is also a large area of need. And as an educational institution, we're a small university, but we see ourselves as providing not only education, but community service opportunities to partner with people within the community to improve the health of that community as well. So please don't forget about us that are outside the city, but still doing our best to serve the community in which we live. Thank you.
Am I on? I join you in congratulating that this was such a great session, and it was last year too. I'm Janice Benson, and I'm with the University of Chicago and North Shore also. But mostly, I spent most of my career in the Cook County Health System and practicing in Englewood. So I really appreciate your presentations. I'm very interested, I think the main thing is, I was shocked that, of course, we have to deal with this $60,000 a year median income difference between Black and white families, and that's the big thing. Looking at smaller things, I'm also intrigued by your description about hyper-local solutions. But I first want to ask Dr. Griffin about Aetna Better Health, because I know you have worked on having incentives around preventive care, and even like kids being immunized should get free clothes. What are the incentives that you're finding are useful and that maybe should be further disseminated to others as well?
Sure, thank you for the question. Sometimes it varies from year to year, but some of the incentives that are used most are the clothing option, and we've changed that. Initially, we had an incentive for school clothes or school uniforms for our child and adolescent population. So now we just changed that to any type of clothing for them. And also for our maternal population and our members that are growing their families, we provide seats what are they called? Car seats, thank you, I'm sorry, I'm having a brain fog moment. But we provide car seats. And we've had to do some education around the benefits that our members can receive because they weren't using them. So we have really found again that our members were not aware of all of the benefits that were afforded to them, which is why we did this campaign to educate and make sure that we're putting it out there in front of them. We have some community development, a community development team. They go out into communities, they host baby showers, they provide farmers markets and fresh produce. They are available at various health fairs throughout the state of Illinois, even in northern Cook County, to make sure that, again, they're bringing the things and the items that our members really need and that they're asking for.
Can I just ask, could you link the increased immunization rates or change with the incentive around getting clothed if the kids are immunized? Is there a link between the public health outcome too?
I don't have an answer to that, but I'm going to let my
Thank you.
So we are not using clothes, we're using food because of the things that we have, and we have a partnership with Olusimbo where people can get up to $100 food voucher or discount of the grocery stores. And this year we see a 27% increase in COVID and flu vaccination. I was at a vaccination today because of that partnership. So that's relative to last year. So we feel like for us in Chicago, that's been something that's been successful.
Let me take a hit at this from the suburban cookie, please. So we have, no, not food, not clothes. I think our incentive is really meeting people where they are. So we've embarked on a series of, I don't know, I think it's about 20 or so Saturday clinics, utilizing the ambulatory clinics as a part of the larger Cook County health system to move around geographically in suburban Cook County and to make sure we're meeting folks where they are. So sometimes it's about being at the right place at the right time in the preferred way, in the preferred venue. So that's one of the ways we're trying to increase our immunizations for COVID, flu, and RSV.
Thank you for your presentation. I'm Dr. Bill Werner with Washington Square Health Foundation, and I'm also on the Board of Health in my local community. One thing that the pandemic brought to the forefront is the public's distrust of science, of healthcare, and of public health. On a community-based level, what can we do to then restore that trust, especially if we're looking at another pandemic that may not have the attention that it's going to deserve?
Great question. There's a lot that we can do. There's some examples of things that we are doing. I'm sure my colleagues will rolling some things out as well. So the first lesson I would offer is that the work has to be done in times of calm, not chaos. Because when the stuff hits the fan, it's hard to establish and ramp up trust. You already have to have those relationships in place. You have to have those partnerships in place. You have to have that trusted kind of bi-directional communication, all the things you need to have in place so that you can flip the switch and say, hey, we have something extra for you to know about, a call to action and things like that. So that's one of the things, work in calm and not times of chaos. Two, harness the lessons that we learned from this last pandemic. One of the things that we learned in doing focus groups up in our jurisdiction is that a lot of folks don't really understand the value of public health. They don't really understand the unique value proposition. They don't understand what we do. In some cases, we had some focus groups where some of the responses were, the lines are too long whenever I go there. Well, they were confusing us with Cook County Health and Hospital. We don't have lines because we don't work that way. And so one of the things that we learned as a result of that is we have to be better marketers in terms of what it is we do in selling the value proposition and helping folks understand what we do. One of the things we did is we created a campaign around building healthier communities and created some animated graphic novel characters called Public Health Heroes League. And it's a way to kind of encapsulate some of the main functions and characters in public health, so you can know there's folks that go out and do nursing, there's folks that go out and do inspection, folks that do community engagement and education, there's folks that and the other. So it's kind of a fun way to get folks to really understand through these animated characters and some of the social media things we use and some of the stories and video, that we are here kind of protecting, safeguarding the health of the community. We're here to work with you, things like that. So it's just trying to be creative and trying to engage with them and do a lot more co-creation instead of, here's what we're doing, we're going to give this to you, but how can we create venues, how can we show up at tables that you've already set, local municipalities, et cetera, so we can share with you what it is we're doing, how we can benefit you, what our unique value proposition is, so that in times of chaos, now we have this ready, this trust that's being built. So there's a number of levels. Those are some of the things we're doing, and there's others. I'm heading here, and go ahead.
Thank you. So we started by actually collecting data and asking people. So there's trust in people and then trust in institutions. We found that in the city of Chicago, only about 32% trust the governmental institutions. And the reason for that is every day you hear that a black person was shot, somebody went into for cancer, and if they're black, they're more likely to die. Or black women are 2 times more likely to die. I said in the city of Chicago is 6 times more likely to die. Then the question becomes, why will I come to your institution when I hear that 6 times more likely to die if I'm a person of color? So the trust in institutions, so we mapped what do people trust, who do people trust, as a pathway to get trust in the people and put the message in the mouth of the trusted messengers to get to people who have had bad experiences with those institutions and trying to rebuild the trust. And then trust in institutions by becoming trustworthy. What does becoming trustworthy? You cannot trust someone that's not trustworthy because they have not always shown up consistently for us. So like Dr. Hasbrouck is saying, is showing up, being in the community. I'm a commissioner, I spend all my time in my office and people don't know me. And then all of a sudden I say, put this vaccine in your arm. But like, who the hell are you? You're like, so how do I make myself visible? How do I make sure that I am in the communities understanding what the issues are so that when we are framing messaging, it is tailored to the realities of the community. And so we have to work as institutions on becoming trustworthy. What do we pay attention to? Whose issues do we, if I get a 311 call from the loop, you'll be there in 15 minutes. If you get a 311 call from the south side, nobody comes in 3 days. And if we say now this is our 311 response and we are going to be sure that whatever is happening in the group is what is happening on the south side, then we start to become trustworthy. So these are some of the changes that we are making. So we don't think that people are going to trust us until we become trustworthy. And that also needs more representation of people who are trusted in positions. So those are the 2 additions I will add to what we're doing.
And I guess the other thing I would add too is when we think about, we've talked about racial culture, ethnic culture, but really understanding the differences between the dimensions of diversity, right? The LGBTQA community, the older adults, people with disabilities, they're all going to respond a different way based on their experience. So I think that's the other piece that when we think about not just the service we provide, but the education piece and the messages is understanding how they're hearing. What is a vaccine? Why are we doing this? And so I think, yes, a lot of trust, but there were a lot of campaigns that targeted those different populations. So it's not just our ethnicity, but it's our entire experience.
And I'll just add that, on a more granular level, research can be done truly from the very beginning in partnership with patient advocates and community advocates, and that's really the way many of our cancer centers function. So for instance, all grant reviews for pilot funding that we allow, clinical trial approvals, major strategic initiatives, everything is done with a community partner evaluating, deciding, and elevating that research. So the research is truly a partnership from the beginning to end. I think the tangible measure of the success of that approach is that, for instance, at our cancer center, UI Cancer Center, 85% of the accruals on clinical trials are either Black, or Hispanic. And most cancer centers struggle to have representation that matches the state or county population. So bringing your patients, bringing community directly into the research process, making them embrace, understand, and advance the research. They are truly the researchers, the research partners, I think is really critical. Whether that can be done on a national scale might be challenging, but I think this is a really important step.
Any other questions? Great. Is Michelle still here?
Yes.
Oh, would you like to come up to the front and show us a representative for one of our exhibitors?
Hi everyone, my name is Michelle Hansen. I'm a regional account manager with Novo Nordisk, and we really appreciate the opportunity to help sponsor tonight's summit, so thank you for that. For those of you who don't know who Novo Nordisk is, we're a global healthcare company that has a mission on discovering and innovating medications to really help patients living with serious chronic diseases live longer, healthier lives, and have a mission to prevent and ultimately find a cure for serious chronic diseases as well. So my job is to expand access to medications throughout the Illinois market, and I think the work that IOMC is doing is incredible, and I think it takes a village, right, to have collaborative partners to have a seat at the table or in the room to provide solutions for the problem, and hope to help join those efforts with what you all are doing. So it's incredible work, and thank you for the opportunity.
Thank you for that.
I don't think I have any more housekeeping issues other than a dessert in the bar area. They are delicious. And I just want to really thank you all. I mean, I learned so much on this evening. And if you see on the tables, we also have our annual meeting that's coming up in June. And we have one other event, so you can watch the website. The QR codes are on the bottom of the agendas. So thank you for coming. Please go home safely. Really appreciate it. And I also wanted to acknowledge Dr. Chatterjee. She is the secretary for the board. So that's her other role here. So thank you for joining us. Sorry about your commute. It'll be better going home.